Hey, everybody. Welcome to the We Fix Pain podcast, episode number 14 with Dr. Bill Tortoriello. Man, that's a mouthful. Welcome to the podcast, Doc.
How you doing, Dino? Thank you for having me.
Thank you for being here. We've had some technical difficulties about COVID, Dr. Pappas being sick, so we're getting this done today, right now.
It's happening.
Let's go into a little background about Dr. Bill. Dr. Bill is a chiropractor out in the Chicagoland area. He was a former instructor at National University of Health Sciences. You still teaching there, Doc?
Not this semester. I taught there between 2015 to 2020. And then this past year, I taught 2 semesters again, but currently I'm not there.
Okay. He is a past instructor at NUHS, National University of Health Sciences. He's taught orthopedics. He's taught physical and neuromuscular skeletal assessment. He's taught neurology courses. He's DNS trained, DNS certified. He teaches dynamic neuromuscular stabilization in the United States. And he also is one of the only and few certified pediatric DNS instructors out there. He's also taken courses in the McKenzie method and Shacklock neurodynamics. So he is well-trained, well-versed, and he is here to help us understand the topic and field of pediatric rehabilitation. So, Doc, thank you once again for your time.
Thank you. I sound amazing. That's unbelievable.
You are amazing.
People ought to be
I'm going to brag on Dr. Bill. A little known fact, my daughter, she was born and she could not get out of a position. She was frank breech. We ended up doing a C-section. We tried to avoid it at all costs. And as a result, we were concerned about her developing hips, that poor girl. We were a little bit slow to act. They recommend braces, and we decided against the braces. So at a certain point in my daughter's development, I pick up the phone, and who do I call? Not Ghostbusters. The next coolest thing, Dr. Bill, to assess my daughter. So if I trust Dr. Bill in assessing my child, he is a really good, because I vet the people that, fix my dishwasher, that fix my laundry machine to the nth degree. So I vetted Dr. Bill, and he helped my family out in a time of our need. So that's why he's here.
I appreciate your consideration. Thanks, Dino.
Yep. Dr. Bill, what's your superhero origin story? How'd you end up in the field of chiropractic, and why'd you get an interest in pediatric rehabilitation?
Well, when I was an undergrad, I knew I wanted to be a physician. I wanted to be a doctor, but I did not want to work in a hospital. I didn't want to be a surgeon. I wanted to do primary care. And I just didn't like necessarily the track of a medical primary care physician. Nothing wrong with it, just wasn't for me. My family growing up always went to chiropractors. Funnily enough, I had never personally gone to a chiropractor before entering chiropractic school. But again, it was never anything out of the ordinary. Chiropractors, at least in Illinois and my family, were just considered a physician. So I liked the idea of being able to handle painful complaints that I at least consider most primary care complaints are painful complaints. I like the idea of being able to handle it conservatively and personally. I'm not going to send you to somebody else to take care of your pain. I'm going to treat it myself. I really like that idea. Luckily enough, being from Chicago, growing up in Chicago, I had National University of Health Sciences in Lombard. I just got lucky. I consider NUHS a great school. I got a great education there. It gave me a good foundation to be able to go on and take the specific courses that I wanted to take to be able to be the kind of physician I wanted to be. While I was at school, I took all the MPI courses and rehab courses I could take because that's just what I was interested in. I liked the idea of physical medicine. Had good teachers there like Dr. Elder kind of telling me, okay, well, if you're interested in this rehab stuff, you should try to find a DNS course. I think he had mentioned the name Pavel Kolaj. Other people were starting to talk about it. He also mentioned the name Robert Lardner, who, as some of you know, is a DNS instructor and was at the time. He's a PT in the Chicagoland area. So between that, I went to school. I graduated in 2006. Could not locate any DNS courses at that time. You couldn't find them on the internet. But I did find Robert Lardner. And Robert, I started to observe him, follow him around in 2006, and then he put me on to the DNS course. In 2007, I took my first course. It was the only course I think offered in the United States in 2007. It was in Arizona. And I watched Collage himself assess and treat infants at that course. And I've said it before, but I was horrified. You know, the baby was screaming. He's seemingly just holding them, pinning them down to the table. And it was like, I was looking around thinking, what the hell did I get into? But, you know, as these things go, 2 years later, I'm taking a pediatric course from Collage. You know,
makes absolute sense, right?
I wanted to be the one to pin these babies down and make them scream and cry.
That's it. Why not?
No. But, you know, the idea is that once you understand the DNS perspective on physical medicine and development, then I started to think, you know, with my adult patients, if I could have just gotten to these patients when they were children, when they were infants, maybe I could have really made a transformative change for them. So they, you know, getting to them as a 42-year-old who has skeletal changes and adaptations and postural things, it's difficult, in my opinion, to really make fundamental change. Whereas if I can get them as infants and children, I really can make a fundamental change. So that's really what caused me to say, okay, let's take a closer look at this and get into it. Took DNS courses from 2007 on, every type of course they offered, really. In 2014, I went to Prague for the first time and became a certified DNS practitioner, as well as a certified pediatric practitioner. Kept taking courses, and in 2019 was asked back to Prague to become an instructor. And as you said, because of the pediatric credentials that I had, I am one of the only certified pediatric DNS practitioners that can teach the pediatric DNS courses. So that's
you guys are like the Marines, the few, the proud. There's only a handful of you guys.
Well, I mean, it's a small group of people that are even willing to take these courses, because not a lot of people want to get that deep into the pediatrics.
Doc, let's do some fun things for people to get to know you. I know you. We're both Chicagoans. Our thick Chicago accents may come on out. You and I can debate who's got the better Italian beef, who's got the best, Polish sausage. That's it, right? So we can debate that, but people need to get to know you. I think it's important. They know your superhero origin story, and you gave us some really great information. Let's do five fun, random, quick little blurbs about you. So what's your favorite Italian dish?
Oh, favorite Italian dish. You know what? It sounds dumb, but if you're lucky enough to actually go to Italy, in Rome there are 4 pastas. They're simple pastas. There's carbonara, there's alla gricia, there's cacio e pepe, and there's a matriciana. And they're all based on the same thing, but I got to say alla gricia, pasta alla gricia. If you could find that, it's basically just olive oil, garlic, onion, and then something. It's not pancetta. It's guanciale. It's a different kind of meat. I think it's even like cheek, something like that they put in there.
It's pork though?
It's pork, and it's absolutely delicious. Yeah.
Gotcha. I have to look that variation on up. You got to win a karaoke contest. What's your winning song?
Oh, John Mellencamp, Hurt So Good.
Really?
Yeah, I don't know if you're asking because you know already, but I actually was a singer in a cover band. So
I did know that. I didn't know you're a big Mellencamp fan. Did not know that.
No, that's.
I have a funny Mellencamp story that we'll tell you off air.
Okay.
Yes, it's for our listeners. It's good, but it deflects from the topic, and I think Dr. Bill will appreciate that story. All right, what's your superhero power?
My superhero power is to be able to annoy my wife in any situation. We can be in Italy, we can be at Disneyland, having the best time in the world, and I will annoy her.
So she got the engagement ring, the wedding ring, and she got the suffering, apparently.
That's funny. I'm gonna remember that.
3 rings. All right, Cubs or Sox?
Cubs. I'm a North Side guy. Although I don't really care at this point. I don't even care at this point.
Yeah, they're both pretty bad. We're going to end this interview right now because you said Cubs, FYI. Last one. Your favorite spot or your secret spot in Chicago that nobody knows about but now will?
Nobody knows about. I mean, from my perspective, because I'm obviously, I'm from Chicago with my last name. Obviously, I'm Italian. There's an Italian lemonade stand called Mario's Italian Lemonade on Taylor Street.
Yes. Chicago.
It's different. If you think you've had Italian ice, you may have, but Italian lemonade is different, and Mario's is the best. So
it's the best. Mario. Yeah, 100%.
Yeah.
My favorite secret spot is there's a point you go on the south side on the lakefront path. It's Promontory Point, where the dimension of the lakefront it rolls southeast. It's a great spot for a picnic because you're looking back at the Chicago skyline. So you set up a picnic, you take some really postcard picture views of the downtown and the lakefront down there because it turns southeast. You get really good views of that. So my secret spot is to go out there, have a picnic, hopefully not get shot. And then south side of Chicago, right? And then, and if you're a true South Sider, the H is silent. It's South Side. You don't say the H. And, it's a great spot to go. All right, back to the topic at hand. What is the pediatric rehabilitation? I think there's a misconception where people think pediatric physical therapy, and they adapt adult physical therapy where a patient will just do a bunch of exercises for an orthopedic condition, and it's supervised, and they modify sets, reps, and loads. I think that is pediatric rehabilitation for a child. I don't think so. So we're here to get the record straight. What is the field of pediatric rehabilitation?
Okay. Number one, pediatrics, you have to understand, is 0 to 18 years old. So this includes, obviously, teenagers, but it also includes infants, babies. To be able to assess an infant, obviously these children cannot verbalize and tell us what exactly is going on with them. Their parents could, of course, tell us that it seems like the baby is having a problem doing this or that, but of course we don't know for sure. So ultimately, the assessment and examination of an infant is totally neurocentric. It's essentially a neurologic exam. It's based on 3 things. Observation of spontaneous movement. This is a fancy way of saying we watch how the baby moves, we watch the postures the baby uses, we watch the quality of stabilization and support the baby uses. That gives us an idea of how the baby's central nervous system is developing. A second thing is we analyze things called postural reactions. Postural reactions are basically whole body global responses to changes in position of the infant's body. And we can talk about some examples, but basically, me as the physician or the doctor will change the baby's position in space quickly, and the baby ought to respond globally, meaning into the hands, into the feet, into the hips, into the head and neck, pelvis, all of the entire body globally responds to this change in position. And the baby ought to typically respond in certain ways at certain times. So a newborn, when I lift the baby straight up in the air, will respond in a certain way. That may differ when the baby is 3 months old, 6 months old, 9 months old, 12 months old. So these global responses will, number one, give us an idea of how the central nervous system is developing, and it gives us something to periodically check on reexamination, and we can go back and see if we're making progress in our treatment. Lastly, the third thing that we check is something called primitive reflexes. Basically, nothing more than your typical kind of reflex. There's a whole variety of reflexes that we can check. Reflexes that are only present for the first month in the child's life. Reflexes that aren't present until 6 months or 9 months of life. There's primitive reflexes that are essentially pathologic reflexes that should never be present. So we're checking these things to see essentially how the baby is developing. And when we use, or at least when DNS talks about the baby's development, we're talking specifically about how their brain or central nervous system is maturing over time. There is an ideal maturation process, and that ideal maturation of the central nervous system will be illustrated or exemplified in the spontaneous movement, the quality of it, in the postural reactions, and in the primitive reflexes. So this is our way of telling whether or not the baby is developing adequately over time without being able to communicate with the baby, essentially. And that quality maturation of the central nervous system then gives quality structure and quality function. So the baby can roll over in both directions. The baby can crawl. The baby can squat. The baby can verticalize and stand up using a quality pattern. And that quality pattern, those quality movements, are a result of a quality central nervous system, basically.
So input in, output out. Output out is the baby can crawl. The baby can get into an uprighting position. The baby can reach or grasp for things, all dependent on the input that they receive, which the central nervous system processes it and then pushes it out. So basically what you're doing is using specific types of development and different stages to test and assess how is the central nervous system developing this child.
Yeah, I mean that is kind of it. It's, I know because of my understanding of motor development what typical babies ought to be capable of doing at certain time frames. And I know the quality in which they should be able to do it. So there's quantity, meaning we use the term quantity to talk about just like things that they're capable of doing. Can the baby crawl? That's quantity. It crawls at about 9 months old. But then there's quality.
The quality, it's a yes or no response. Can they crawl? But how they crawl is really what you're alluding to. Yeah,
that's right. And the postural, and number one, the observation of the quality, the analysis of the postural reactions and primitive reflexes gives us a window into the central nervous system to predict the quality. It tells us, okay, something is going on with the central nervous system, so this is why we're seeing poor quality. That's essentially how it works. And then when we start handling and treating the babies, of course, we expect to make changes in the central nervous system that will produce changes in the quality that we observe and changes in the postural reactions and reflexes. So we treat for a little bit, then we go back and we check those three categories to see if we've made improvements.
To get good at this, you really have to have a deep grasp at what normal development is. Is that something that's drilled into you over and over and over again? Because if you don't know what normal is, you may not find the abnormal. Is that fair? Like you need to have a really good grasp at what normal development is, and it's predictable and the time frames and all of that. Is that fair?
100%. I mean, that is what DNS provided. DNS is grounded in something called developmental kinesiology. Again, just a fancy word for motor development. There are textbooks on human motor development. This is basically what occurs through the first 16 to 18 months of every human life. In the seminars, I say it doesn't make a difference if you're a baby in Chicago, in Prague, or in Iceland. You will develop your nervous system in the exact same way using a particular time frame. And this is hardwired into your central nervous system. It's not something that you're consciously aware of. Babies aren't consciously making the decision to stabilize at a certain point and to do certain activities. Of course, there is a certain amount of nurture where parents are goading the child to turn to their right or reach into this direction. But ultimately, the stabilization and the patterns that are used are hardwired into your subcortex. So there's no conscious activity there. These are things hardwired. So there is a certain time frame that at 1 month, at 3 months, at 4 months, at 6 months, at 7 months, at 9 months, certain things are happening that are typical and considered ideal, and that's what we're looking for.
Doc, the better you get at this type of assessment, it becomes more so like pattern recognition, right? Like initially it's so foreign to look at how children at this age move. And then you consciously kind of understand like something ain't right, but I don't know what it is. And eventually you start realizing the norms and you start sifting through the abnormals and say that pattern is not appropriate and best matches blank diagnosis. Is that how this evolved for you?
Yeah. I mean, it's like you're saying, similar to adults. You start when you see somebody present with a particular type of posture or a particular type of gait. You start to, with clinical experience, you say, okay, I think this seems to be what's going on, and of course you assess them. Same thing with infants. There are patterns that recur. For example, one of the major things for DNS is the sagittal plane stabilization needs to occur in the lumbar spine and pelvis by 3 months old. So by 3 months,
why?
You need to see something. Well, because that is the very first time any type of controlled stabilization occurs in the infant. So between 0 and 3 months, of course, a baby is moving and flopping around, but it's totally uncontrolled and essentially non-purposeful movement. At 3 months, by 3 months, they start to coordinate the activity of the abdominal wall muscles with the activity of the diaphragm muscle. This changes the position of the thorax relative to the pelvis, and that enables the muscles to function in a stability function. So this is where we get into, there are multiple functions of all muscles, including even the diaphragm muscle. We all know the diaphragm is responsible for respiration, but it is also responsible for primary stabilization. So one, key pattern or key thing that we're always looking and always checking for is, can this baby attain primary sagittal stabilization? And if it can't, usually there's a pattern of hyperextension in the lumbar spine, rib cage flare. So if a new patient or a new parent brings their baby in, and at 6 months old, and they lie them down on the table, and I see the pattern of a rib cage that's flared up and out that doesn't seem to be able to change its shape, I already know, based on clinical experience and based on my understanding of development, that, yeah, something's going on here. The baby is not capable of stabilizing properly.
For our listeners, when he talks about rib cage flare, when you look at the lower ribs, one of the things that you can do is take your hands and get underneath the soft tissues of those lower ribs. The ribs will have to flare up and out for you to be able to do this. So not only do you get an observation, but if you can visualize the ribs flare like this, I can sink my fingers in. That's the rib cage flare that Dr. Bill is describing. I just wanted to back up because some people may not know what that rib flare is. Sure.
And there's, just like everything, there's even varieties of rib cage flare. It can flare wide. It can flare directly A to P. It can be a combination, but essentially there's a clinical presentation of rib cage flare that
And that rib cage flare is indicative of
lack of quality of sagittal plane stabilization. And that's important because that is the very first source of any stabilization in the body. That should occur by about 3 months, should be solidified by 4.5 months old. This is what allows a baby to flex its hips and raise its legs up and off the table in a controlled way. This is what allows a baby to grasp objects in front of its face or to its side. This is what allows a baby to then rotate and turn from its back to its belly. Now, again, I'm not saying, and DNS doesn't say, that babies won't raise their legs up, they won't reach for things, they won't even roll over. They will do these things. But this is where quality comes in. If a mom comes in and tells me that my 4-month-old, yes, my 4-month-old rolls over from its back to its belly, there's quantity. Yes, it checks off. It can roll over from its back to its belly. But I'm going to say it's probably not doing it with quality. There's a particular way in which it needs to be able to do it, and that primarily involves that sagittal plane stabilization that we're talking about.
One of the things you mentioned when we talked about your superhero origin story was the way that you can impact somebody in youth and have more impact on them by intervening. Intervention could be observation, exercise, manual therapy, information to the parents about what normal and abnormal is. You mentioned that that was something that really attracted you to the pediatric population. Fast forward, somebody lacks sagittal plane stabilization at that critical point in that development. What does that potentially project forward into later stages of development, into teenage years, into adulthood? What does that potentially project forward towards?
Well, in one sense, I would say it's not rocket science. I would say generally, if you lack quality sagittal plane stabilization of your lumbar spine and pelvis, then when you attempt to load your lumbar spine and pelvis, you will be loading it using poor quality support, poor quality stabilization. Some people might be able to get away with that for a certain amount of time. Some people might even be able to be athletes using that type of pattern. A lot of people will end up just injuring themselves or causing symptomatic pain, and they say, I don't want to do this anymore. I'm every time I play this sport, or every time I try to lift this weight, or every time I go for a run, my back is killing me afterwards, so I'm done, and they just stop. And then potentially they stop having symptoms, and that's it. But you end up forming poor quality patterns of stabilization. DNS sometimes gets a bad rap for the idea that people take a DNS course and think that everything needs to be perfect and ideal in order to be effective and good. That's not necessarily the case, but we do believe that there is something called quality stabilization versus something that is called poor quality stabilization. There is something that is poor quality, and it is based on, you can sometimes indirectly base that on biomechanics and observation, but ultimately it's still a neurologic, neurocentric dysfunction where this person at 22 years old, at 42 years old, when they bend over and they lift something, they are using a poor quality stabilization pattern that may have been ingrained in them when they were 3 and 4 months old, and then propagated over time, and they somehow got away with it for a certain amount of time. And then, they herniate a disc, and they repetitively herniate a disc, and they present in your office. That's kind of how this works. Or at least that's
so. Let's project that case forward. Child can't move, stabilize the sagittal plane. For most of our listeners, that's bending forward and bending backward, flexion, extension. We're going to use the lumbar spine. If they can't stabilize that, they'll develop a compensatory pattern. The more you use that compensatory pattern, the more the part of the brain that generates motor response, how I move, the cerebellum and other parts of the brain learn it. It's a learning computer, machine learning, rep by rep by rep by rep by rep. The tissue doesn't wear out until it wears out. Fancy words for it needs enough stress and stress to specific spots of the tissue over and over and over again before it hits a load tolerance. At that point in time, tolerance, your demand demand exceeds supply, right? Supply demand curve. You're demanding more than the tissue can supply. that's when the disc herniation occurs, the disc bulge occurs. But your analogy, what you're speaking to is the pattern was the evolution of this potentially occurred years before when the development did not occur properly and the baby didn't learn how to stabilize.
That's right. When the pattern was established to begin with.
Gotcha. And just got reinforced over and over and over again.
Yeah. And the tricky thing is that there are plenty of people that have poor patterns that might not be very symptomatic or might not have a history of chronic injury or pain. So you start to think, well, everybody has poor patterns and not everybody has symptoms. So poor patterns must not be a real thing. There's no such thing as a poor pattern. And I would argue that's not the case, that if you actually examined people, and particularly neurologically examined them from a neurocentric perspective, you would find that the people who so-called didn't have any symptoms, they are very sensitive to palpation. They have muscle weakness. They have range of motion loss and asymmetries. And while they might not have overt pain, they do have these dysfunctions that you can pick up on a quality exam.
How do we define ideal movement? Because that's been debated. There's normal, there's normal-ish. It doesn't look right, but it doesn't create symptomatic responses. And I'm not saying symptoms are the end-all, be-all. I think you can have reduced function and not have symptoms. And I think you can function just fine for your task and be mildly symptomatic. So there's a whole spectrum in there. But one of the knocks is, how do we really define quality movement? And how do we know what's normal, normal-ish, or, hey, don't effing do that, right? Don't effing do that at all, right? Yeah. Because like the most common debate that I see in my population, at least the nerds like me, is, do you need to flex a little bit to lift a weight from the ground, or do you got to maintain a neutral spine? Is it okay to extend a little bit? There's shades of gray in there. How do we define what's normal, normal-ish for the average person?
Yeah, that's obviously, that's one of the key questions. That's a good question. The DNS perspective says number one, there is something called ideal movement. And I would say that the quality and the ideal movement, whether we're talking about a posture or whether we're talking about an actual movement pattern, there is superficially based on objective biomechanics, visualization of biomechanics. But more fundamentally, it is based on the neurodevelopmental perspective. So the example is, if you gave me a photograph of somebody holding a posture, or a photograph of a golfer mid-swing, and said, is this ideal? Is this showing quality? What I would say is, superficially, I can make a very good guess based on biomechanics whether or not something is quality. Ultimately, if you had my hand to the Bible and made me bet all of my money, I would say I can't bet, because I have to assess this patient globally before and after they use this posture or use that movement pattern to see how that posture or movement pattern impacts their central nervous system. So, again, just to kind of repeat that, it's the central nervous system, everyone's central nervous system, has hardwired programs in the subcortex that are the definition and objective standard of ideal and quality. That's not necessarily controversial. But those patterns that are hardwired into the central nervous system produce a movement pattern and a structure that influences your biomechanics that is typically consistent and repeatable. So that's where our norms of range of motion come from. The fact that we all have brains that were hardwired produces norms of ranges of motion of biomechanics. But when you look at it from that perspective, those norms of biomechanics, again, come from your central nervous system. So I do not want to just simply rely on the biomechanics. I want to rely on the nervous system. So when I watch somebody bend over and do a deadlift, I can watch them, and from the norms of biomechanics, I can say, this angle here, this amount of neutral spine or flexion extension seems to be there. But ultimately, I am going to globally assess you before you do the deadlift and after you do the deadlift. And if your central nervous system responds poorly to the pattern that you just used, I don't care whether or not biomechanically it looked good. Ultimately, your nervous system is telling me whether or not it's good. And so that's kind of where my definitions of ideal come from. There are norms that you can standardize to everyone, and that comes from the programs that are hardwired in your central nervous system. But ultimately, I'm not going to rely on those norms. I'm going to rely on my ability to assess you neurologically.
So what you're referring to is like essentially using like an audit process. Your audit process takes into consideration what's ideal development of a child or an infant, what strategy you're currently utilizing, whether it's a 5-year-old, a 10-year-old, 12-year-old, 15, 18 adult. So what are the developmental norms, what strategy you are using, what baselines you're assessing in terms of muscular tone, muscular tension, pain, not pain. You load a specific pattern. Can you repeat that? Was it an efficient movement? And then you're utilizing that criteria, pretty much checks box. Was that ideal for you or not for you?
Yes. That's right. I do have an idea in my head of what typical ideal patterns look like and typical norms of biomechanics look like. And those typical norms and ideals come from the neurodevelopmental perspective. But I can't solely rely on the biomechanical perspective. I have to, like you said, audit them neurologically before and after to ultimately tell me. The other thing, just to remind everyone, is that this idea of can I look at a picture and tell whether or not it's ideal? The other aspect of this is ideal and quality for DNS does not mean neutral. You can have an ideal pattern in full lumbar spine flexion. You can have quality stabilization in full extension of the lumbar spine. It isn't one specific biomechanical position that is the ideal. It's the idea that in every biomechanical position possible, there is an efficient and effective way to stabilize it. And ultimately, the only way to know whether or not you are using the efficient and effective strategy is to audit them before and after, because you can't just rely on what it looks like. You can't rely on them telling you, yeah, that felt pretty good. You can't rely on them telling you, I did 10 reps of it and didn't hurt afterward. None of that is reliable. You have to have some type of objective neurologic test before and after to see how it's impacting their central nervous system. One phrase we use is central nervous system doesn't lie. You can tell me
hips don't lie, except it's a central nervous system.
Exactly. I might put that in.
I think you should put that on a T-shirt, and on the front you just be like, the central nervous system doesn't lie, quote, Bill Tortoriello. And on the back, you have a person's hips don't lie, Shakira. You got to make that a T-shirt now.
Yeah, that's scary.
Wear it to your own courses.
Right.
Real quick, we're going to transition the conversation here in a little bit because there's a bunch of other questions that I'd like to ask you, and I like to solicit questions from my colleagues and peers that they like to ask you as well. So I want to transition. Let's hammer home 2 or 3 points here on the pediatric assessment. So what baselines in the child that you keep going back to that are like your 2 or 3 key assessments in the child? And then can we use those 2 or 3 assessments, adolescents, teenager, and adult? So give me like 2 or 3 off the top of your head that you utilize, and you can even utilize those concepts projected forward to different age demographics. Okay.
So to be able to project forward through the age demographics, that's a little bit more difficult because, two of the standards for the assessment of the infant are these postural reactions and primitive reflexes. You can't do a postural reaction on an adult or a teenager. Postural reactions involve me lifting the infant up in the air and turning it on its side, me lifting the infant up by its leg upside down. So obviously we can't do that with children or adults. Primitive reflexes, like the name implies, they're primitive, ought to be, most of them, 99% of them, ought to be gone by 1 month old, let alone 6 months old, 9 months old. So you're not really going to be checking those things on adults. Now, functional neurology gets into some primitive reflex stuff with adults. That's not my area of expertise. I'm not exactly certain of that. But what you can translate throughout the infant, to the child, to the adolescent, to the adult is the quality of support. For example, when an infant at 6 and 7 months old in prone presses down through its hands to raise itself up and off the ground, there's a certain quality of support through the hand, elbow, shoulder, head, neck, thorax that I want to visualize and see. That is the basis of upper body support. That is the same pattern I want to see when they're 9 years old, when they're 16 years old, and when they're 24 years old. If I put a 24-year-old or a 40-year-old in a quadruped position, I want to see a certain quality of support and stabilization through the hand, head, neck, and shoulder. So I'm using the patterns of development and stabilization that develop in the infant, and it's translating throughout the entire life. Similarly, like I said, the postures that are used. For example, infants in supine at 3 months old ought to be able to change the position of the rib cage relative to the pelvis in order to get that stabilization. That changing of the position of the rib cage is what I want to see on all of my adult patients when I ask them to do things. So if I ask an adult patient to move in a certain way that requires this stabilization, I want to be able to visualize and see them change the shape of their rib cage. And if they can't, just like a baby might not be able to, that gives me information about the quality that they're using.
And I want to project this forward. I work for a company, and we treat neuromuscular skeletal conditions. And I'm going to use an example that applies to a lot of our practitioners. Dr. Bill is talking about with the hand on the ground and stabilization. It's important because we give people push-ups plus. We give people wall angels. We give people wall slides. And what he's talking about is when the elbow goes into the wall for a wall slide, or you're doing this clock drill up against the wall, you need stabilization of the cervical spine, wrist, elbow. This reflex that he's talking about directly applies to our exercise prescription and even our assessments. We can even assess this out. Oh, you've got scapular flare. I know that along the chain, you may need scapular stabilization, or what's the basis for scapular stabilization? Proper respiratory patterns. Right?
You're right.
So we can use this concept not just in a child. You can use these in a adult-centric, like what we do, neuromuscular skeletal practice, to tease out and parse out where they are, what exercises I need to get them, and what am I looking for if they're grooving these patterns as part of a home program. Is that fair to say?
Oh, yeah. That's 100%. I mean, that's it. That's 100% it. It's number one, just simply understanding what you just explained. When they put their hand down, that hand being in support function is now feeding back into the nervous system, and then the nervous system, like the words you used before, outputs a certain pattern. And there's quality patterns and there's ineffective, inefficient patterns, and you have to be able to tease this out and find out where the breakdown is coming from. Is it at the wrist? Is it at the elbow? Is it in the scapula? Is it in the thoracic cage? Or, I mean, is it even, like you said, a problem of respiration at that point? Can they not breathe in that pattern? This is exactly how it works.
Can you give us a couple other examples off the top of your head? Because I want to translate the pediatric stuff into, what we see a lot in our offices in our company, and that's we typically see folks, teenagers, 13, 14, 15, all the way up into geriatrics. Can you give a couple other examples where understanding these developmental principles will help us identify the functional pathology and then game plan into a comprehensive care plan, manual therapy, rehabilitation exercise? There are a couple examples that broach that gap from childhood until what we see and treat in our offices.
Okay, that how I would approach that is, patient comes in complaining of hip pain. When the patient comes in complaining of just local hip pain, obviously we all do our primary assessment examination. We rule things in and out. We can treat proximally in the spine. We can treat in the pelvis, and we can treat in the hip. Once we kind of desensitize the patient, settle them down of any kind of acute pain, you can then start to implement particular patterns of support, stabilization, and movement that, of course, favor the hip. The thing with DNS is DNS doesn't have a hip exercise. They have global whole body exercises that impact every segment of the body. Now, there are certain exercises that, of course, load the hip a little bit more. So, for example, with somebody with a hip complaint, I go into the catalog in my brain of development and human motor development, and I say, okay, well, at 6 and 7 months old, babies use a pattern of support and movement called oblique sitting. This oblique sitting loads the hip through the knee or even the foot. So I'm going to use this pattern of oblique sitting to load my patient's knee and therefore load the hip and attempt to get this patient to feel the quality of support that is necessary to perform an oblique sit properly. Now you might say, well, yeah, but this patient isn't moving around on the ground. They're up moving around. They're walking. What I would say is the neurodevelopmental perspective gives us an objective framework to say, yes, but walking around on a hip is harder to stabilize than being on the ground in an oblique sit with the hip. And if they're having trouble evidently walking around with a hip and loading it, I don't want to start them there. I want to start them on something easier, something that they can... threatening
for the nervous system.
That's right. That's right. That's a very good way to put it. Less threatening for the nervous system. I want to give them the easiest way possible to load their hip effectively. So I will start using that developmental framework and work my way through it until ultimately they have fully verticalized, and we're using the principles of support through our foot to load the foot and train them in a more vertical position. So that's one thing off the top of my head in terms of like a patient with hip pain. The other thing though is, myself and Robert Lardner teach a particular DNS course that we've been doing for the past few years called Integrative Assessment. And we're really trying to get after a quality screening and assessment process that will give us the right to give the patient the DNS exercise. One thing about DNS, at least in the typical courses, is that you take an exercise 1 course or an A course, and You learn the developmental process, you learn functional assessments, you learn the exercises, and that's all great. But ultimately, the assessment that they show you is a functional assessment. You don't, a patient comes into my office, I don't immediately start functionally assessing them and telling them to do an exercise. I have to primarily assess them. I have to do the typical range of motion, manual muscle testing, neurologic testing, and then desensitize their pain, whatever they might have. I can't just immediately give them an exercise based on a squat test. And DNS says this outright. They assume you have assessed them before you're going to do a functional test and give them an exercise. So when we're talking about this, hypothetical hip pain patient, I would say you have to understand that I would have treated and gotten rid of any primary proximal problem of their spine, of their pelvis, of their hip before I start giving them functional exercises like loading the hip.
Gotcha. What Doc is alluding to essentially is, right place, right time. Simple as it boils down. If the nervous system's coming at you, it's painful. It's a hot hip, hot low back. You're not going to have them start going into rolling patterns, crawling patterns. First, you need to take it. That didn't make sense. Not at all. I was guilty of this earlier in my career. I had all these movement screens, and I was orthopedic tests mean nothing, right? They're not specific. You need clusters of them. We're just going to watch them move. We're just going to have them gait assessment on everybody. That's actually the wrong approach, because you're getting the wrong. You're not only going to piss off the patient, you're getting the wrong information, right? Yeah. And information is not clinically worthwhile at that time. So this is when you got your other tools, and Doc's got a toolbox of using your hands-on therapy, using your modalities, using your McKenzie method, put out the fire, using your neurodynamics, and then at the right time, using the lens of what is good movement, what is stability, what is proper movement, what is ideal movement, is the movement relevant for the task, asking those questions, but when the fire is put out.
Yeah, that's right. And I'm guilty of all of those things you said. I mean, it's you start when you go down this path of physical medicine and movement and all of this stuff, and there's experts and gurus out there that essentially proclaim this. It's just get the patient moving, load them, get them strong, and that in one sense sounds nice and good, but if they have if they have a derangement. If they have a real true dysfunction, you can't just start loading and doing all of these things. You do have to do some type of primary assessment and primary treatment beforehand.
Doc, how do we transfer these skills, these forms of assessment using this lens into an outpatient neuromusculoskeletal orthopedic practice? Like, how is this transferable, and how do we transfer this style, this lens of evaluation and treatment?
When you say transfer, are you talking about to the patients or to other practitioners?
To an integrated, not just to the patient, but to a practice style. Like, for example, I see patients every 30 minutes. I have a finite amount of time with them. I think some people worry that the assessment that, using this dynamic is either too complicated to put into one-on-one 30 minutes, or hard to teach a rehab specialist that they work with exercises, these evaluations, or the patient is not coming for that. They're coming for, manual therapy. They're coming for manipulation. They're coming for, pain relief. Yeah. I'm trying to think of some obstacles that people would have to put this lens of evaluation into clinical practice. So how do we fit this in?
This is difficult. Even personally, I'm a DNS instructor. I've been doing this for a long time. Do every one of my patients get DNS exercise? No, they don't. Because like you said, they just want to be there. They're there to be adjusted. They're there to be rubbed a little bit. They're there to recommend a stretch, and they go home. So that's one aspect is, of course, there's a certain population of patients that They're not motivated. They're not interested. They're there just, like you said, to get a little manual worker adjusted. So they're out the door already. It's just not going to happen for them. The patients that are there to get what I would call a more integrative, holistic treatment, it's difficult. It's difficult to manage the time because from my perspective, you have to do a quality assessment before and after the treatment. I can't do an examination on Monday and then treat you Wednesday, Friday, the following Monday, Wednesday, Friday, and then recheck you 3 weeks from now. I can't just rely on you to come back and say, oh yeah, I think I feel better. Or my pain's a 3 out of 10 and it used to be a 6 out of 10. That to me is practically meaningless. I have to assess you before and after each treatment. Now, whether I'm going to assess you or whether I'm going to provide the treatment, maybe that in an integrative practice, you have rehab specialists who you have taught how to do these prescribed exercises and do them well. But ultimately, me as the physician have to be able to assess you and then guide the rehab specialist and tell them, okay, this patient needs this particular exercise for this particular reason. Then I tell the manual therapist or the massage therapist, this patient needs this type of work on this region because for this reason. So, for me, I work alone. So I'm seeing, the typical patient that is actually getting this type of work is usually a 45-minute visit, something like that. I do charge them accordingly. But if I was placed into a more integrative practice, I probably would be outsourcing the exercises to the rehab specialist, and I would almost be the assessment specialist. I would be the one providing a good quality assessment to really hone in on what is actually going on with this patient. And that's not going to take 45 minutes. Not most of the time. I could screen people out and assess them and get an idea of what they need in a reasonable amount of time. So and it can be treated, obviously I'm here, and I do it. So I have a bias, but the course that Robert Lardner and I have put together over the past few years is really attempting to do that. It's really attempting to hone in on a rational assessment that will screen everything out and lead you down a path of where we need to treat, how we need to treat, and then we get into the specifics of, which DNS exercise are we going to use and how are we going to use it? Because even having taken the normal DNS courses, people come away and say, okay, when would I use that exercise? How would I use that exercise? The integrative assessment course that Robert Lardner and I put together is essentially trying to answer that question too. It's once you kind of get the Rolodex of exercises in your head, now it's how can I apply these exercises in a rational way?
Yeah, and for the folks out there watching this podcast, the most beneficial utilization of the theories and concepts for me makes me understand how to really simply progress and regress specific exercises that you already know, right? Like I use the example of a wall slide or a wall clock. Elbows are pushed into the wall. You're sliding one side up or in multiple different directions. Well, I can make that infinitely harder by putting you on the ground and having you doing it in a bare position, right? Where we're using your body weight in a different position and requiring different stabilization. And I am now assessing you for what are your cheating strategies? How are you cheating around the problem? And if I take you from just doing this on air to doing it modified on the wall to doing it in a bare position where you're sliding your arm here and I see loss of stabilization, it gives me the idea to regress that back to the wall, to do it on air, or just to pick a different exercise, right? We want to challenge somebody at the limits of their capacity. And if their capacity is producing a non-quality stabilization pattern, guess what? Regress it. And the concept of this DNS, pediatric evaluation, just gives me the tool and the confidence to say is I can use these positions with already understood exercises to really simply make it harder or make it easier, but effectively it's the same exercise for the patient.
Yeah. And and that's right. It's what you just described is the framework that DNS gives you enables you to confidently say why the bear position is in fact harder, and it gives you a rational way to talk about regressions and progressions.
Or another good one is like, I have a tough time in my clinical practice giving an exercise like a Turkish get-up, but there are portions of a Turkish get-up that deal really well with developmental positions that help me solve the problem of I don't need to go through 5 or 8 progressions of a Turkish get-up. I can just give you 1 or 2 little microcosms that work on your deficit, right? And those things may benefit you more in rehabilitation. And it's not an 80-year-old on the ground trying to get up. It's putting you in 1 or 2 positions that stimulate the adaptation that we want. And that's how I utilize some of these concepts is a hack. Hack is a bad word. It's a solution to a problem of I can challenge somebody using these concepts more in an outpatient neuromuscular rehabilitation practice like what we have. Hey, Doc, real quick, thank you for your time. I want to close this down. What are 3 big takeaways?
3 big takeaways, I think, are that, from my experience, and of course I'm biased, but DNS is the only approach that gives you a fundamental objective framework to look at movement and stabilization. Every time if I hear of any course, if I hear of any approach or therapy or anything, at this point, I'm measuring it against a developmental framework. The developmental framework is universal. It's genetically hardwired. It cannot be argued with. So that is a standard that we can use. So that's the number 1 framework. If you're interested in physical medicine and teaching people how to move and stabilize effectively, you ultimately have to know development. You just do. It's like knowing gross anatomy. Another takeaway is that I want people to understand that DNS is not about having to make everything perfect in order to make it good and effective, but there are still shitty movement patterns. They do exist. There is something called a bad movement pattern. There's bad quality stabilization, and it is not based on purely pain or symptom production. It is neurologically driven. And if you actually take the time to assess people, you will find neurologic problems when you assess these people that have so-called poor patterns. Lastly, hopefully it's been coming out throughout the whole talk, is that you can translate everything you learn in a pediatric assessment and treatment directly to the adults. I mean, it's a joke because obviously a lot of my pediatric patients, they come from the parents who I'm treating. And a lot of the times we laugh because the mom will say, you're doing the same exercise with the baby that you're giving me. I'm doing oblique sit and the baby's doing oblique sit. And I say, that's right, because you need to learn shoulder support, and so does your baby needs to learn shoulder support. So it is a perfect transition and it's a perfect illustration of these are fundamental patterns, universal patterns that everybody needs. Lastly, I'll give you a 4th thing that we might not have specifically said. The treatment aspect for DNS pediatrics is about handling the baby. How do I physically handle the baby? The treatment aspect is guided exercise. So yes, I am exercising newborns. I am exercising 3-month-olds. I'm exercising 6-month-olds. What am I doing? I'm placing them into the appropriate developmental positions and attempting to get them to load them. I'm attempting to get them to feel what it feels like to load in particular postures. This hopefully causes a reflexive response in their central nervous system that gets at that hardwired program. And I teach the parents to do this. So in between visits, the parents are doing the handling and the guided exercises. So that way we can give these babies as much time and experience with a good posture and good input so that hopefully it actually does get into the brain and change and impact the central nervous system in a positive way.
Hey, Doc, thank you. Where can people find you? You mentioned a couple times that you guys are teaching these courses. So where can people find you, and what's your upcoming course schedule like?
So you can find me at, I run the IMTR Seminars Facebook page and Instagram page. That's Integrative Manual Therapy and Rehabilitation. It's the seminar, it's the group that I use to host DNS seminars. IMTR Seminars on Facebook and Instagram. I always keep it updated, and it shows the courses that we're teaching. Most of them are done in Chicago, but this next year we are branching out to Florida, and hopefully we'll be teaching a couple courses across the country. Coming up in January, there's still an early bird discount for the integrative assessment course. There's 2 parts to that course. One is in January. The second part is in April. I'm going to be teaching a DNS Exercise 1 course in Chicago in February. Still time to do early bird discounted rates there. And I just
announced Chicago in February. Game over for me. Not coming back in the winter.
Oh, no, you're not interested?
Not cold weather. Not like that anymore.
Oh, my God. And I just announced.
I lost it. It took me 3 years to lose that hardcore. I could tolerate this cold 3 years.
I'll turn the heat on for you. Don't worry.
Thank you.
But I just announced that the Florida DNS exercise series, that's going to be in April and June of this year. So we'll be down like near Tampa as well.
That's nice, good area, and you get some beach time.
Let's
work on your olive oil skin, your Italian olive oil skin.
Right.
All right, Doc, thanks so much for your time. We're closing this down. I'm Dr. Dino Pappas. That's Dr. Bill Tortoriello. It's a mouthful. Hopefully I got it right one more time. Thanks to everybody for watching the We Fix Pain podcast. We appreciate all the support. Please make sure if you like this episode, you share. And if you're watching this on YouTube, hit subscribe, turn on those notifications. Thanks, everybody. Bye, Doc.
Thanks.